Okay. Welcome, everybody. My name is Andishe Attarbaschi. I'm a pediatric oncologist in Vienna. I'm also in the SAP Europe board and very much involved in ERN PET-CAN. And yeah, I welcome you to this Young SIOP ERN PET-CAN organized webinar. And it's my great pleasure to introduce two great people to you. First of all, Fiona Poyer. She's working at Meyer Hospital and she's going to present you a very challenging and dramatic case of a progressive T-cell lymphoblastic lymphoma. And the other one is Marta Pillon. We know each other for years and she's an expert in pediatric non-Hodgkin lymphoma and working in Padova. So the floor is yours, Fiona, and I ask all participants to ask questions, put questions into the chat. We will try to address them all. So Fiona, the floor is yours.
Thank you very much, Andishe, for this kind introduction. I'm very happy to be here with all of you, and I'm sending you greetings from the sunny Maldives, where I am currently at. It was a great pleasure and challenge to work on this case, both clinically, but also to put it in a presentationable form, because as you will see, it was quite complex. These are our conflicts of interests. And the patient is a 16-year-old adolescent who was diagnosed with a T-lymphoblastic lymphoma. On the left side, you can see the X-ray with the mediastinal masses compressing on the trachea, amongst other things. His minimally disseminated disease status in the peripheral blood and the bone marrow were negative, but as you can see, he had blasts in the liquor, classifying as a CNS3, so CNS positive patient. Regarding the genetics, both stratifying mutations, Notch1 and FBXW7 were wild type. So due to the genetics, but also due to the CNS status, this patient classified for the high risk group. Our patients were all treated or are still all treated according to the LBL 2018 protocol. And this patient was included in the first randomization and randomized to receive dexamethasone in the induction. So after prephase, this is the protocol at a glance from protocol 1A, and he received treatment according to plan initially, and he responded extremely well. Already at the lumbar puncture on day 12, there were no more blasts in the liquor, and also the chest X-ray showed a regression of the masses. So I put the CR with question mark because technically you cannot really speak of a complete remission at this time point, but just to show you that he responded extremely well. In our center, we do an echo, a heart echo, an ultrasound after every second dose of anthracycline. So on the day 22, he had a routine ultrasound of the heart that showed in a completely asymptomatic patient, first that the central line is a little bit too far inside the atrium, almost in the ventricle. But most importantly, you could see that there's an intracardiac thrombus with almost 1.5 centimeters. And there was a lot of discussion what we should do about this, and the recommendation from our cardiologist as well as the cardiologist of the Medical University of Vienna recommended a removal, which was tried by a catheter, but it didn't work. So this patient had open heart surgery on cardiopulmonary bypass to remove this thrombus. This by itself probably would have been fine, but unfortunately on the second post-operative day, the patient developed severe stomach pain, and then acute CT of the abdomen showed a massive necrotizing pancreatitis. You can see here that the pancreas is almost completely dissolved, and probably this would have by itself been enough for a systemic inflammatory response syndrome, but this occurring after such a huge surgery sent the patient almost into multi-organ failure and led to an intensive care stay of 2 weeks with mechanical ventilation and the need of catecholamines. The patient then, or the pancreatitis to be more correct, as it's not unusual, continued to develop pseudocysts, and even though the patient recovered clinically and was transferred back to the normal ward, to our ward, and these side pseudocysts grew to be massive. This one is 10 centimeters in diameter, for example, And then the day after his transfer to the normal department, he went into shock, like clinically developed symptoms of shock. And the ultrasound showed massive bleeding into one of the pseudocysts. So the patient was again transferred to intensive care unit. And this is what happened to the patient over the course of the next 8 weeks, amongst other things. So he had 2 extracorporeal drains placed, 2 gastrocystostomies, over which more than 50 endoscopic necrosectomies of the necrotic tissue in the abdomen were performed. He developed a passageway insulin-dependent diabetes, exocrine pancreatic insufficiency. Due to the autodigestion in the abdomen, he developed an aneurysm of the vena lienalis, which had to be operated on again and was fixed by coiling. And during these 8 weeks, he had multiple episodes of peritonitis with sepsis, again intermittently leading to mechanical ventilation and also intermittent need of catecholamines. So my first question now is, the timeline here we're talking about is more than 2 months. With a lymphoblastic lymphoma that was responding well to treatment, but it has not been treated sufficiently. So what do we do with the lymphoblastic lymphoma treatment in this patient? For those who join by phone, I think you will see a multiple choice question pop up. And for those who joining online through the browser, I think you can answer the question in the chat. So would you pause treatment or give a low-dose treatment with either dexamethasone only or low-dose chemotherapy? Would you go for alternative therapies, immunotherapy? What would you do?
Okay, I can see what's in the chat. Only 2 answered yet in the chat. Perhaps I see some familiar names in the chat. Please answer.
Just to be fair, this was a massive discussion, a massive interdisciplinary discussion. So there is no really a right or wrong answer. So it would just be interesting what your maybe gut feeling would tell you to do. And then I can show you what we decided to do.
Okay, 5 people answered in the chat. 6. 5 would do low dose chemo, 1 would pause the treatment. This is what I see in the chat.
Okay, so should we continue with the presentation?
Yeah.
Okay. So what we opted to do, as I said, it was a massive interdisciplinary discussion. We were very scared to stop treatment altogether, but especially our intensive care specialists and the specialists from the Medical University of Vienna were reluctant to give even low-dose chemo because the patient was so unstable. So we opted to give several courses of dexamethasone as a monotherapy because, as you can remember, the patient was disease-free at onset of symptoms, and we did several lumbar punctures, chest x-rays, and also bone marrow punctures to confirm that the patient was still in complete remission. Miraculously, the patient recovered from his toxicities, not fully, but to the point where he could again be transferred to the normal pediatric oncology department. And on the day after his transfer, he woke up with a facial nerve palsy. So we performed a lumbar puncture that showed a couple of blasts, but less than 5 leukocytes per microliter. We also did a bone marrow puncture in the same anesthesia, and unfortunately there we saw that he had 85% of T-lymphoblasts, so almost a leukemic relapse progression. And this comes to the next question, which I'm personally interested in, because that also was a discussion. Can we call this a relapse, or is it a disease progression? And some might say that this is just a semantic question, but that actually, in our opinion, it meant a lot for the risk evaluation and also to estimate if the patient has a chance of recovering from the T-lymphoblastic lymphoma and what treatment we will offer him. So again, go to the chat and let me know what you think.
We have 5 replies. It looks good to me what the people are answering. 6 people answered and they all call it a progression.
Okay. This is also what we decided to call it because since the disease has never really been fully treated, we hope that this disease might still be chemosensitive. The patient was stable enough and also the lymphoma was progressing so fast that we decided to now try a low-dose chemotherapy. And we gave the patient 6 mercaptopurine, 4 doses of vincristine, and performed lumbar punctures with intrathecal triple therapy 4 times in a row. And as we hoped, the disease seemed to be chemosensitive because at the 3rd lumbar puncture, he was blast-free in the liquor. And at the bone marrow puncture at the end of this course, he was in complete remission in the bone marrow. He still had a low MRD load, so it was still positive, but there were morphologically no more blasts visible. But even after this very low dose of chemotherapy, the patient became extremely sick again. He developed multiple intra-abdominal abscesses, one of which you can see here. This was the one causing us the most problems because it led to complete obstruction of the gastrointestinal tract. And again, he developed systemic inflammatory response syndrome, which led to intensive care stay, catecholamines, and a short period of mechanical ventilation. What I failed to tell you earlier on is that at the time point of relapse, we also sent probes of the bone marrow to Zurich for a drug screening to see if, first of all, the disease is chemosensitive, but most importantly, if there is any alternative treatment that would work well on this patient. And it came back with the recommendation that either we do chemotherapy because it was still chemosensitive, or if we want to do a different approach, the combination of venetoclax and dasatinib seemed to be reasonable for this patient. So after the patient had recovered from this, again, severe toxicity, we started him on venetoclax dasatinib. But 2 weeks after the onset of these 2 drugs, he complained of a progressive loss of vision. We again performed the staging and we could see that there were again blasts in the liquor as well as 67 T-lymphoblasts in the bone marrow. So now again, what do you offer the patient? Would you stop treatment now? Would you try again for a low-dose chemotherapy that led to toxicity? Or would you say, okay, it's all or nothing now and let's go into a high-dose chemotherapy scheme?
Briefly lost Andishe, but he's back now. And
okay. Maybe just in the meantime, to help you all, the family and especially the patient himself, who at this time point was already 17 years old, had an immense treatment wish. So they definitely wanted any sort of treatment. Andishe, do you see the answers of the poll?
No, I don't see any.
It is three answers for low-dose chemotherapy and 3 answers for high-dose option. Yep.
And that pretty much sums up all the discussion that we had in our team as well as internationally, because there were the voices who said it's all or nothing now, and if the family wishes to do so and we tell them the risks, then let's do it. And there were some that said no, already the low-dose chemotherapy causes so much toxicity. So we opted for a slow increase of chemotherapy intensity. We again started with a pre-phase of 6 mercaptopurine, vincristine, and dexa. When he tolerated that, And we still saw that the disease was miraculously extremely chemosensitive, because after this pre-phase, he had a PCR MRD of 10 to the minus third. We then said we are going to escalate and try a protocol 1B, because that T-lymphoblastic diseases respond very well to this treatment element. But unfortunately, he showed a progression on an MRD level, a PCR MRD level. So then we went into a high-dose chemotherapy block containing, amongst other things, high-dose methotrexate. But unfortunately, there was further progression. The HR block was tolerated reasonably well. So we decided to give him another one, this time containing high-dose cytarabine, which kept the flow MRD at a stable level, but unfortunately showed no real response. So we then gave the last available high-risk block, but then there was a full-on progression. The patient still hardly had any severe toxicities from these blocks, and they still had, this family and the patient himself begged us to try everything that we can and give the most intensive treatment block that we can find. So also after international discussion, we decided to give a Burkitt relapse block. This time was toxic. The patient again ended up in intensive care with need of catecholamines, this time no mechanical ventilation. But unfortunately, also this block came too late, and the patient progressed again and then succumbed to his disease. So my take-home messages from this case, or what I personally learned from it, is first of all that this case shows that major ongoing toxicity can compromise the success of a treatment protocol, even in a highly curable disease, and especially if this toxicity already occurs in the crucial treatment element that is the induction block. And this patient also always reminds me that finding the ideal therapy, there is, in these cases, hardly a clear answer on what to do. So it should always be a balance between aiming to cure the patient, balancing that with the treatment toxicity, but most of all, also take into account the patient's individual wishes. Thank you very much for the opportunity to present this case, and I'm looking forward to the discussion.
Yeah, thanks a lot, Fiona, for bringing this patient at this webinar so precisely. And it was a challenge for the whole team, as you said, and also for me personally. You very nicely showed the different important topics, having an adolescent patient, having this severe toxicity so early on, knowing about the very poor prognosis such a disease has if it progresses so early, and so on and so forth. First of all, I would be very interested to hear Marta's opinion on this case. And then I would invite the people in the audience to ask their questions. You can either speak up or put your question into the chat and I will read it up. Marta.
Yes, thank you. Thank you, Andishe and Martin for the organization, and thank you, Fiona, for presenting this interesting clinical case that gives us the opportunity to talk about the toxicity during chemotherapy treatment for lymphoblastic lymphoma. Just 2 words about lymphoblastic lymphoma. That is a rare lymphoma. This is the second most frequent non-Hodgkin lymphoma in children and adolescents. Therapy used for acute lymphoblastic leukemia has also been shown to be effective for lymphoblastic T lymphoma. Event-free survival is between 75% to 80% with a different approach using for ALL leukemia. These results were achieved at the price of a severe toxicity, as you can see in this case. Interesting, overall survival overlapped with event-free survival, demonstrating that patients who relapsed or in disease progression are unlikely to be recovered. In 2017, Landman published in Hematologica the results of EURO-LB02 protocol. And in this paper, we have an interesting table 3, if Martin can show this table. treated and present the treatment-related mortality, especially happened in phase 1 and in induction phase, in the first and second part of the induction phase. In this case, patients were randomized in prednisone versus dexamethasone. But the major part of toxicity we have in during prednisone in the group of prednisone, random prednisone, but during the dexamethasone phases. And regarding this clinical case, we can see that the role of asparaginase is very critical, and it is responsible for thrombosis or other clinical situation that block and cause a stop of chemotherapy for days or weeks. And we know that if long discontinuation of therapies occurs, as in this case, we may see either disease relapse or disease progression in case of patients was not in CR. And recovering the patient can be very complex. The therapy that we can use can depend on the clinical situation of the patient. We can use a targeted therapy such as bortezomib, daratumumab, or high dose of chemotherapy as high dose for use for ALL, or combined therapy such as Birgit Burkhardt suggests in this period, bortezomib plus vice. But if the patient has severe complications of therapy, only low dose therapy, like in this case, can be used. And the Fiona showed us that the patient can use only dexamethasone or low dose of methotrexate plus mercaptopurin. And only in the second phase, they try to recover the patient, to rescue the patient with high dose of chemotherapy, because this was, on my opinion, the only choice for this patient to reach a CR. And in this case, the use of block 1, 2, and 3 that we can use for relapse of leukemia cause severe aplasia, and this situation rise the sepsis, as in these cases. So this in particular is a severe clinical case from the beginning, because we know that the involvement of CNS is very critical, as well as the relapses on CNS is the very, very difficult cases to treat. Another observation is that high dose intensity protocols can be used only in very specialized centers, capable to manage these adverse events in a multidisciplinary approach, because as you can see, surgery, intensive care unit, and the meeting with expert is in any case very, very complex. To try the correct way to treat so difficult patients is very, very difficult. This is my opinion.
Yeah, thanks a lot, Marta, for bringing all this to the point. I can add one very short comment. I think people could ask us why are you using again dexamethasone in the LBL 2018 trial when we look back at the EuroLB 2002 trial where we stopped the randomization? The reason was that since we stopped prophylactic cranial irradiation from the NHL-BFM95 trial onwards, we had an increase of CNS involving relapses. And we didn't want to go back to cranial irradiation prophylactically. And due to the results from the EuroLB 2002 trial, we made a slight change that we give dexamethasone for only 2 weeks and not for the whole induction therapy. So these were our thoughts when we developed the LBL 2018 trial, being of course aware of the fact that DEXA is significantly more toxic in induction than prednisolone, especially when you give DEXA at 10 milligram per square meter per day. I have a question to Fiona before the other people ask, because I cannot see any question in the chat and I cannot see any hands up. Fiona, do you think we should have done something different in this patient? We discussed the patient a lot. We had a lot of conversations within the team. I had a lot of conversations with the parents and the patient himself. Should we have done something different?
I don't think so, to be honest. Not because we're the greatest and we know it all, definitely not. But I think mostly because of the things you said. We had many discussions up to the international experts. We had many discussions amongst the team. We had many discussions with the parent and the patient. And we were, there are several things that we have been asked. Maybe should we have given more intensive chemotherapy early on, but we might have killed the patient with doing so. That he actually tolerated the high-risk blocks at the end, that was an extreme surprise. We thought, or we were very scared that we were going to cause life-threatening toxicity even at that point. So I don't think we should have done something differently. One of the big questions was also not should we have intensified more early, but should we have stopped earlier? And yes. I think there it is important that the patient and the parents were desperate. And I think we were very clear to them what toxicities were possible and that this block itself, especially the wiki block, can be life-terminating even, not just life-threatening. And they said he's going to die from the disease anyway, so they want to try. There were skeptical voices also to that discussion, to that decision.
Yeah, I think this is what I could add for me personally. For me, Marta, please correct me. For me, it was clear that this patient will die. We will not rescue this patient when we saw that the HR blocks don't work. But sitting in front of an adolescent patient who tells you, I want to continue, I would like to continue, brought us to the team decision to give the wiki block, which we all know is very, very intense. And so this is, I think, one of the most difficult situations in pediatric oncology, sitting in front of adolescents, knowing that they will die, we will not cure them, but they still ask you for continuation of therapy. How to deal with that? Marta, how would you deal with such a situation?
Yes. I had a similar situation 2 years ago with a 17 years old boy, and he decided to use a low dose chemotherapy at the beginning, and after a big toxicity after PEG asparaginase in the previous protocol, and we try to convince the family and the boy that we had a chance to cure him, but he decided to use only low-dose chemotherapy. And he died after 1 year, after 2 relapse, because he also using low-dose chemotherapy, he had a benefit, a remission, a partial remission, because he had only mediastinal involvement and no bone marrow, no CNS involvement. But it was a very, very difficult situation for me.
Yeah, this is the other way around, and I think when we sit in front of adolescents, yeah, we have to respect their thoughts and wishes, although they can be, yeah, seen completely different way by us.
Yes.
Okay, still looking for questions in the chat. I think Fiona was, as always, very comprehensive, very precise in the presentation of this case. And yeah, I would like to thank her once more. Thanks a lot for Fiona for also being willing to give this presentation during your vacations.
Of course, Marta, it was a
Marta,
pleasure.
Thank you, Fiona.
Great that you were on board as an NHL expert. For me, it was an honor to have you both here. And I see that around 20 people were in the audience, which is which I think shows that people were interested in this case. I see people I know very well. Madelina is there, Giuseppina is there, Melanie, Angela. Great to see you all here today. But I think it's time to say goodbye. The session is over. I wish you all a nice evening, and those who are at vacations like Fiona, a good vacation.
Thank you, Andishe.
Still good.
Thanks, Andishe. Thank you, Marta, for the collaboration.
Thank you, Marta.
Ciao, ciao.
Ciao,
Ciao, Martin. Martin, thanks for organizing the meeting.
Thank you.
Bye.
Bye.